Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Serina, with my good friend Saba, and today we're diving into a topic that surgeons love and patients definitely feel gastrectomies and post gastrectomy syndromes.
This topic is not just incredibly high yield, it's also pretty excruciating for patients. Hence, why we must be well informed on it to be able to counsel in the best possible way.
So let's build this step by step, starting with the operations themselves, then following the consequences. So, Saba, walk us through some basics.
Gastrectomy procedures range from partial to total stomach removal, often combined with reconstruction to restore GI continuity. First, let's talk about pyloroplasty. Now, keep in mind, this is not a gastrectomy. It's a drainage procedure, usually done to improve gastric emptying. There are three classic types, or so I hear.
You hear correct. So, first, we have the Heineke maculates, which is a transverse incision across the pylorus, closed longitudinally. This one is the most common. We also have Fene, which is with a crescent incision, closed as side to side gastroduodenostomy. And the wonderful Jabulae, two longitudinal incisions with no incision across the pylorus, also closed side to side.
So, pyloroplasty helps empty the stomach, but once you remove the stomach, things get a bit funky. A gastrectomy is when we just do that. We remove the stomach. Now, as we all know, the GI tract is a continuous tube. So, after we remove a part of it, we need to reconstruct the tube. Let's go over the three ways we do that.
So the names can be a tad bit confusing, but when you break them down, you can memorize them instantly. We got the Billroth I, also known as gastroduodenostomy. Here, we connect what's left of the stomach with the duodenum. If you think about it, the duodenum is the first part of the intestine, and this procedure is called the Billroth I. Next, we have Billroth II, or the gastroduodenostomy. We attach the stomach to the side of a loop of the jejunum. This procedure is simpler and faster, but it is associated with alkaline reflux, gastritis, and heartburn. Now, if we divide the jejunum and have one end attached to the stomach and the other, called the biliary limb, is reattached further down, then we call it a Roux-en-Y procedure. Grab your nearest pencil and draw it out. Unless you're driving, then don't let go of the wheel. You'll notice that it looks like a Y. This is also called a gastroduodenostomy.
All right, now that we got some basics down, let's jump right into the various things that happen to us when we remove the tummy.
Let's kick things off with a case. We have Julie, a 30-year-old woman who underwent weight loss surgery a while back. She comes in complaining of feeling dizzy, sweaty, and nauseous after meals. She also reports vomiting and diarrhea.
Classic dumping syndrome. Essentially, the body dumps hyperosmolar contents into the small intestine.
Julie also recalls that somewhere in her medical records there is a mention of Billroth II.
Yep. While we see dumping syndrome in a lot of different cases and procedures, it is usually associated with Billroth II. If you recall Serina, that's when the jejunum directly connects to the stomach. Makes more sense that we see this dumping more with it.
True. And how do we classify dumping syndromes?
Late and early. With early, it happens within 30 minutes of eating and is due to fluid shifts into the bowel lumen.
Right. So volume depletion plus bowel distension?
Yes, symptoms here are like what we saw with Julie: abdominal pain, nausea, diarrhea, dizziness, palpitations, even flushing and diaphoresis.
And what about late?
This occurs around 1 to 4 hours after a meal. The main thing here is insulin. We see hyperinsulinemia resulting in reactive hypoglycemia.
So we see hypoglycemic symptoms, sweating, tremors, hunger, and even fainting.
Yep, and the key thing to keep in mind is that these symptoms improve after eating carbs.
Great. So what do we tell Julie?
Well, here we give advice. We tell her to switch to having smaller, more frequent meals, avoid simple carbs, and avoid drinking during meals. If the case is very severe, we consider octreotide, which mimics somatostatin. It slows gastric emptying and intestinal transit, as well as reduces the secretion of insulin. Pretty effective too, offering relief for 90% of patients. We can also do a conversion to Roux-en-Y.
All right, so let's do a quick pause. How about a question to get the ball rolling?
A 55-year-old woman underwent a partial gastrectomy for gastric cancer. Several weeks after the surgery, she experiences episodes of nausea, abdominal cramping, and diarrhea, approximately 15 to 30 minutes after eating meals. She also reports feeling lightheaded, sweating profusely, and having heart palpitations during these episodes. She denies any fever or chills. Physical examination reveals mild tachycardia, but it's otherwise unremarkable. What is the most likely underlying pathophysiology explaining the patient's symptoms? A. Rapid gastric emptying of hyperosmolar food into the small intestine. B. Delayed gastric emptying due to vagal nerve injury. C. Malabsorption of nutrients due to decreased intestinal length. D. Bacterial overgrowth in the remnant stomach. E. Anastomotic leak.
My gut is telling me A for sure.
Good job. This is the classic dumping syndrome. And when do we see it most?
Billroth II.
All right, our next patient is Alex. He is 39 years old and presents with epigastric pain, nausea, and bilious vomiting. One important detail here is that the vomiting does not relieve the pain.
That already points toward alkaline reflux gastritis, meaning bile is refluxing into the stomach. I'm guessing this pain is also non postprandial?
You guessed correct. The pain is not related to meals, which helps differentiate it from peptic ulcer disease. On endoscopy, we see a stomach that looks beefy, red, and friable, with visible bile reflux. In some patients, we may also see marginal ulcers near the anastomosis.
So, endoscopy is how we diagnose it?
Yes, endoscopy is the diagnostic test of choice. If we want to objectively confirm bile reflux, we can also use a HIDA scan, which demonstrates retrograde flow of bile into the stomach.
Alright, so how do we treat Alex?
We usually start conservatively with antacids, cholestyramine to bind bile acids, and small frequent meals. If symptoms are severe or persistent, the definitive treatment is a conversion to Roux-en-Y reconstruction, which diverts bile away from the gastric mucosa.
Let's go back to those marginal ulcers. Tell me more.
Marginal ulcers, also called stomal ulcers, occur at the anastomosis and are most commonly seen in the jejunal side, not the gastric side.
Why? Why would they even occur?
Bigger way, acid. The main driver is acid exposure at the anastomosis. High yield causes include incomplete vagotomy, retained antrum, a long efferent loop, gastrinoma, or a G-cell hyperplasia and alkaline reflux. These ulcers rarely bleed or perforate, but they can be very persistent if the underlying cause is not addressed.
You keep mentioning loops, which makes me think they cause problems too.
They definitely do. After Billroth II, we are left with two limbs: the afferent loop, which carries bile and pancreatic secretions, and the efferent loop, which carries food. If either becomes obstructed, we get loop syndrome.
Sounds loopy.
In afferent loop syndrome, bile and pancreatic secretions cannot drain. This leads to severe epigastric pain, non-bilious vomiting that relieves the pain, and elevated bilirubin and amylase on labs. In efferent loop syndromes, food cannot pass distally, so patients develop severe abdominal pain with bilious vomiting.
How does an obstruction even happen?
Common causes include post-operative adhesions, volvulus, internal herniation, kinking of the bowel, or an anastomotic stricture. The most feared complication is duodenal stump blowout, which can lead to perforation, peritonitis, abscess formation, or fistulas.
That sounds explosive. Is it really that serious?
Unfortunately, yes. The duodenal stump blowout is the most common cause of mortality after gastrectomy, and it typically occurs within 3 to 10 days post-op.
Knock knock.
Who's there?
A clinical scenario. We have a 70-year-old woman with a history of a Billroth II partial gastrectomy present to the emergency department with persistent nausea, vomiting, and upper abdominal pain. She reports no fever or chills. Her emesis is described as non-bilious. Physical examination reveals abdominal distension and tenderness in the epigastric region. Laboratory tests are unremarkable. What is the most likely diagnosis? A. Dumping syndrome. B. Acute afferent limb syndrome. C. Acute efferent limb syndrome. D. Small bowel obstruction. E. Gastric outlet obstruction.
Non-bilious vomiting that relieves pain after Billroth II points straight to B, acute afferent loop syndrome.
Bingo! Alright, now let's move on to some other miscellaneous syndromes. This part of the episode will be more rapid fire, so now is the time to refill your coffee cup and keep your ears peeled.
First, post-vagotomy diarrhea. This occurs due to vagal denervation of the small intestine and biliary tree, leading to uncoordinated motility.
Patients present with watery episodic diarrhea that is unpredictable and not related to meals.
The good news is that symptoms usually improve with time. Management includes antidiarrheal medications, avoiding foods with meals, and reducing lactose intake.
So, no cheese?
No cheese.
Next up, Roux-en-Y syndrome. Patients complain of chronic abdominal pain, nausea, and vomiting.
This is caused by functional obstruction of the Roux limb, not a mechanical one. The normal propagation of intestinal pacemaker potentials is disrupted, leading to delayed transit.
I assume eating makes it worse.
You assume correct. Symptoms are aggravated by meals and are often associated with abnormal motility of the gastric remnant or pouch.
Stasis always makes me think of gallstones.
Vagal denervation of the gallbladder causes dysmotility and bile stasis, increasing the risk of gallstones. Some patients benefit from prophylactic cholecystectomy, especially if sludge or stones are already present.
And if the colon gets injured during surgery?
We can develop gastric fistulas, either gastrocutaneous or gastroenteric. These can also result from the leakage of the gastroduodenal anastomosis or from the eroding ulcers.
Gastroparesis can also occur, which is delayed gastric emptying without mechanical obstruction. This can lead to bezors.
Bezors are masses of undigested material that accumulate in the stomach or remnant and can cause obstruction.
We also see early satiety, which makes sense given the reduced stomach capacity. This can lead to profound weight loss and malnutrition.
Exactly. Post-gastrectomy patients are especially prone to vitamin B12 deficiency, as well as iron, folate, calcium, and vitamin D deficiencies. Supplementation is often parenteral, since the normal absorption sites are removed.
To wrap it up, weight loss after gastrectomy happens due to 5 main mechanisms. 1. Early satiety. 2. Gastroparesis. 3. Anorexia from loss of ghrelin. 4. Malabsorption. 5. Dietary modifications due to dumping syndrome or chronic diarrhea.
If you understand those mechanisms, most post-gastrectomy syndromes suddenly make a lot more sense. Why don't you hit us with one more question to solidify the info?
A 55-year-old woman underwent a Roux-en-Y gastroduodenostomy 8 months ago for complications following partial gastrectomy. She now presents with chronic upper abdominal pain, persistent nausea, and recurrent non-bilious vomiting. Her symptoms are worse after eating and have been gradually progressive. Physical examination is unremarkable. CT scan and upper endoscopy shows no mechanical obstruction. What is the most likely cause of this patient's symptoms? A. Adhesive small bowel obstruction. B. Anastomotic stricture. C. Functional obstruction of the Roux limb due to disrupted pacemaker activity. D. Afferent loop syndrome. E. Alkaline reflux gastritis.
C. Functional obstruction of the Roux limb due to disrupted pacemaker activity occurs after months of Roux-en-Y, not immediately post-op. Symptoms are chronic, meal-related, and progressive. Imaging rules out mechanical obstruction caused by disruption of normal intestinal pacemaker potentials in the Roux limb.
That was a lot to stomach. Thank you for tuning into PodBites.
Remember to stay healthy, stay hydrated, and eat a pear. Slowly. Well, here are marginal ulcers. ليش هيك حلق لساني؟
Why would they even occur? بس يا زفتة.
شو هي؟ ماما طب ايش احكي bigger way؟ bigger way. يا جماعة